Hello everyone. Now we'll discuss question of neurology. Well, we got a 55-year-old man. He come to emergency with the right arm and right leg weakness. 2 hours ago he noticed, and when he could not grip a pen, he is now unable to shake hand and walks with a mild limp also. Patient had a mild constant headache for the last several days. He had to be due to stress for new projects, and his medical history is significant for hypertension, hyperlipidemia, the two important risk factors for coronary artery disease. But he doesn't smoke and consume alcohol. That means at least one more risk factor is smoking, which is not there. BP is still very high, and mild asymmetry of lower face, decreased muscle strength in the right arm, and positive Babinski on the right side. If you look into this, definitely we are getting right-sided hemiparesis, and there are upper motor neuron feature. Why? Babinski sign is positive, and he has hyperlipidemia and hypertension, and still BP is high. So with this background, we move further. Sensory examination is normal. That means the only problem what he has is right hemiplagia or hemiparesis, only motor involvement, no sensory involvement. Blood glucose is normal, he is non-diabetic, ECG is normal rhythm. Okay, non-contrast CT reveals no abnormality. Well, before I really go into the discussion, first of all, patient had an acute neurological deficit. 2 hours back, and he had right-sided weakness. This is so-called stroke. Sudden onset of any neurological deficit is anything. It's vascular phenomena, unless proved otherwise. So like in this patient, sudden onset of the problem happened. Neurological deficit of right-sided weakness is there. So we are dealing with vascular event, which is stroke. Well, one more thing I like to elaborate, if it recovers within 24 hours, then we call it TIA. And if it persists more than 24 hours, then we call it to be stroke. As of now, we cannot comment on this thing whether stroke or TIA is there, but weakness is definitely there. But one more thing, only motor problem is there. There's no sensory problem. Now the question is, what the most likely cause of the patient's problem? Well, the right answer is small vessel lipohyalinosis is there. Okay. Patient shows a lacunar infarction in internal capsule area. Okay. So before I proceed further, let me tell you some anatomy of the internal capsule. This is the anterior limb. This is the posterior limb of the internal capsule. Here are the corticospinal tract, that is which carries motor fiber. Here we have a sensory fiber which are going up, vision fiber, and auditory fiber. This is the most simplified line diagram to make you understand the subject. Now, corticospinal tract, motor, sensory, eye, vision, and auditory fibers are there quite near to each other. Well, now you have to understand the basic. If only this part is involved, so that will be hemiplegia like in this patient. This usually occurs due to any ischemia. But at times, there may be bleeding also. There may be bleeding in the sense like, look into this, bleeding has occurred. If bleeding has occurred, then it will be not only motor fiber, but there will be sensory fiber may be also involved. So now, isolated motor fiber involved, it has to be ischemic. One more thing. This I have shown you hemorrhage into the putamen, into the internal capsule. In fact, as such, usually bleeding does not occur in the internal capsule. Here we have putamen. Bleeding occurs in the putamen, and this bleeding can go to the internal capsule. The internal capsule is not a direct site of bleeding, it's a putamen which is a usually site of hypertensive bleed. Well, now our concepts are clear. That means we are dealing with only with the problem of motor. So most likely it is ischemic. So now this happened due to lacunar infarction of internal capsule. Definitely because the only involvement is motor fiber. Now this occurred due to occlusion of the deep penetrating arteries in the brain. Okay, deep penetrating artery and they are located in the highly turbulent region of the cardiovascular system. Anyway, deep penetrating arteries are involved. Okay, now what are susceptible? Who are the people who are susceptible to this problem, having risk factor like hypertension, diabetes, hyperlipidemia, and smoking? Our patient has hypertension, our patient has hyperlipidemia. There are two important risk factors which predispose to this type of pathophysiology. Now, why this happen? So again, going back, this is the internal capsule. These are the corticospinal tract. I'll draw only this, what I need to talk to you. This is the deep penetrating arteries are coming. These are involved. So they are involved and they are involving isolated corticospinal tract. Okay, let me draw it like this. Yeah. Now, how they can be occluded? Maybe microathyroma formation or maybe lipohyalinosis. So there are two pathologies that can happen in these patients. That's why the answer of our question is lipohyalinosis. And both these lead to thrombotic small vessel occlusion occurs. Okay. Well, these lacunas are usually often not appreciated in non-contrast CT scan. It's true. Again, one more basic concept. Whenever a patient of stroke comes to you, the first line investigation is non-contrast CT scan. Okay, first. Well, in any ischemic stroke, it may be normal in first 24 hours. Not only for lacunar infarct, even for big infarct also, ischemic lesion, this may be normal in the first 24 hours. Okay, but why we still want to do it? We want to do because CT scan is better to pick up bleeding. It's better than MRI to pick up the bleeding part. So our first investigation is to rule out whether we are dealing with bleeding or we are dealing with ischemia. If CT scan is normal, it is very sure that we have ruled out the bleeding. That's why we want to go for non-contrast CT scan for any case of stroke. Okay, why not contrast? If it's a bleeding, then we cannot differentiate between blood and the dye. So we always use non-contrast. We never use contrast in hemorrhagic, wherever hemorrhage is there in the brain. Well, so lacunar infarct commonly occur in the internal capsule. This lead to pure motor hemiparesis due to injury to the corticospinal tract in the internal capsule. The point I mentioned in the previous slide with diagram. This involves contralateral face, arm and leg, posterior column, sometimes corticobulbar tract also. That is when the lesion occurs in the genome. I'll show you the picture, this also. Now look into this. Lovely anatomy picture. So what we are getting is anterior limb. And what we are getting is posterior limb. In the posterior limb, we are getting corticospinal tract. Okay. And these are the corticospinal tract and these are the corticobulbar tract. These are the so-called thalamic, that means sensory system. And they are the corticopontine fiber. Right. The genome, we are getting corticobulbar. In the posterior limb, we are getting so-called corticospinal tract. Well, patients typically have motor weakness and sensory deficit depending on contralateral. Remember, sensory deficit will happen only when bleeding occurs. But lacunar infarct, only motor weakness will be there. Can the sensory deficit may occur? Yes. In lacunar infarct, as I told you, this is the posterior limb, anterior limb, corticospinal tract. They're the sensory fibers. This is motor fiber. If this also get involved, motor lesion, if this also get, that can have combination of motor and sensory. But by and large, motor is, of course, both can happen. Either way, this can happen. Okay, so contralateral face, arm and legs will be involved. But what are the signs which are typically absent are mental status changes, seizure, and cortical sign. These do not happen. And this will happen only when it is happening in the lobar. Lobar means the proper brain parenchyma like middle artery, hemorrhage or stroke. When this entire lobar area is involved, then we can get this type of problem. But otherwise, in so-called lacunar infarct, these signs are not there. They are very, very important feature. Even in our case also, patient was walking, he was limping, but he was fully conscious. Now look into this. I talked to you regarding so-called artery, the lacunar stroke, and the artery involved are lenticular artery, which are I talked to you regarding deep penetrating arteries. So deep penetrating artery example are medial and lateral lenticular artery, which arise from middle cerebral artery, which are going to supply to internal capsule. Look into this. Lovely picture. We are getting lipohyalinosis, microatheroma, the thing what I mentioned in the pathophysiology. They are you can getting infarct. Okay, this the middle cerebral artery is there, and we are getting lenticular artery. Lovely summary of what I discussed regarding lipohyalinosis, microatheroma. Everything summary is there. Well, later on, in the first 24 hours, it may be normal, but in due course of time, later on, there can be, you can see lacunar infarct are there. Okay, infarct are there. Due course of time. By first 24 hours, they are usually normal. Again, you can see infarction. Well, let's look into other option. The bridging vein rupture. This leads to subdural hematoma, and this due to rupture of bridging veins. Usually they have headache, maybe have headache, altered sensorium can be there. Altered sensorium. Seizures, focal deficit may be there. But in the initial stages, patient may not have any problem. Simple headache, which may be progressively increasing due course of time. Non-contrast CT will reveal a concave hemorrhage that crosses the suture line. Let me show you. This is the bridging vein. First of all, basic concept. This is the bridging vein. This and rupture occurs here. Okay. Well, now again, lovely picture. Superior. This is the superior sagittal sinus. With the bridging vein is draining, the much better picture here. Superior sagittal sinus, and we are getting bridging veins which are draining into the superior sagittal sinus. Right. Well, now this is the CT scan. You can see you are getting a concave shape, and it is crossing the suture line. Subdural hematoma. But now I have a question for you. Why subdural hematoma is very common in alcoholic patients? Beautiful questions there. Stop the video, write down the answer in your copy. Well, as I told you, these bridging veins, they can be ruptured sometime even by a trivial trauma also. Not in all trivial trauma. Sometimes they can be even ruptured by trivial trauma also. Okay. So in alcoholic patient, there is no point in taking history or trauma. Have you ever got injury in the head? He may have a heavy drunk, and he may have fallen any time. So that's why it's very common in alcoholic patient. The classical presentation is long-standing headache, and which is progressively increasing and deteriorating day by day. Since it's a venous bleed, so it takes lot of time to accumulate the blood. It's never, usually doesn't happen immediately. Of course, it can happen acutely, but more of a chronic subdural hematoma may be there, or it may just present with some time as a dementia also. So whenever we are getting any case of dementia, it's mandated to do CT scan to rule out subdural hematoma. So all these are important points. Rupture of Berry aneurysm. This leads to subarachnoid hemorrhage. And in this patient, a sudden headache. It is very severe headache. Never experienced before. The classical history, there may be neck rigid may be there. Why? Because there is irritation in the meningism is there. Fever is usually not a feature, and urgent CT scan is needed to diagnose it. Carotid artery thrombosis, it leads to profound neurological deficit. Homonymous hemianopia contralateral, hemiparesis, hemisensory loss, and due to ischemic infarction of the cerebral hemisphere. Cortical sign and altered mentation are there, point to be noted. But I mentioned in the previous slide that in lacunar infarction, these are not there. But when we are getting cortical sign and mental changes and seizure also, sometimes patient may have seizure. If these are associated, then we are definitely dealing with lobar type of hemorrhage or lobar type of problem. It's not a lacunar infarction. Meningeal artery rupture, due to traumatic head injury, it leads to epidural hematoma. It's sudden headache is sudden, nausea, vomiting, focal deficit, ulcer, sensorium. All these occur very fast. Why? Is a arterial tear. This is in contrast to subdural hematoma, which was venous bleed. That's why venous bleed is slow to progress, and in contrast, the patient comes very fast. Sudden headache and altered sensorium in a couple of minutes only. And now come the question to you. Stop the video, write down the answer. Trauma we mentioned. Which part of the skull this traumatic lesion lead to meningeal rupture, meningeal artery rupture? Stop the video, write down the answer. Which part of the skull rupture or trauma occurs? Well, the answer is, it is parietal lobe. Somewhere here, not the parietal lobe, you can say lateral aspect of the skull, like somewhere. Okay. So, temporoparietal skull, this area rupture occurs in the skull. Okay, now what happens? This is the skull. This is the dura. Here is the middle meningeal artery, and middle meningeal vein. This is skull. This is dura. Now, when this trauma occurs at this place, temporal bone to be more precise, this artery will get rupture, and immediately the blood will accumulate and lead to this. You get a convex finding of bleeding on CT scan. Okay. Well, you can see lovely finding, lovely picture, convex finding. It doesn't cross suture line. This is in contrast to subdural hematoma, which crosses the suture line. Now I have one more question for you. Stop the video, write down the answer. What do you mean by lucid interval? Stop the video. Well, as I told you, when the bleeding occurs, immediately blood gets accumulated, because bleeding is occurring from both middle meningeal artery and vein. Blood accumulates. It suddenly leads to increased intracranial pressure, and patient become unconscious immediately. Unconscious. Later on, in due course of time, the CSF will go down to the spinal cord. Patient will transiently regain conscious, and the transient regain conscious is lucid interval. But again, ICP will rise. Again, he become unconscious. So unconscious, conscious, and unconscious, and this in between period of consciousness is known as lucid interval. Okay, so now we are clear about it. So golden line to remember: lacunar stroke are due to microatheroma formation and lipohyalinosis. The small penetrating artery of the brain, especially lenticulostriate artery of the middle cerebral artery, often affect the internal capsule and result in pure motor hemiparesis or sometimes pure motor and pure sensory also, depending on which part, which segment is involved. Hypertension, hyperlipemia, diabetes, smoking are the major risk factor, which are the risk factor for coronary artery disease also. Thank you very much.